Move on to our last talk of this session. I'd like to invite Dr. Safeshi from the Sarah Cannon Cancer Institute at Swedish Medical Center in Colorado, and he'll talk about the challenges and opportunities with translating clinical trial science to community practice. Thanks, Boris.
Well, thank you very much for having me. My talk is going to be a little bit different than all these scientific talks, and as I transition more to a community practice, what I struggle with these days is how do we actually apply all of this information? I mean, we all over here can find consensus in terms of what we do, but it's not as easy to do that in a community practice, and I think we have a lot of work to do with that. These are my disclosures. So right now we could probably consider the standard of care. Maybe this slide is not completely conclusive, but these are our options for early stage lung cancer, right? We have discussed Checkmate 816, Keynote 671. We presented some cases. Hopefully this year we may anticipate approval of Checkmate 77 and Aegean. So Empower 030 we haven't heard about, and then we have all these adjuvant options that are both immunotherapy based or TKI based. So when we discuss these things in multidisciplinary conference, at least I think that everybody should kind of know these things, but when you work with general oncologists who also treat breast and maybe GI cancers and some of the other ones, all these nuances that we discuss over here are sometimes challenging, and we even heard varied opinions in terms of how to treat stage 2 disease versus stage 3. And the most important thing, obviously, is molecular profiling, and that's also not the easiest thing to do in the community in a timely fashion. So there's education still that has to be done with physicians, with supportive teams, and definitely with patients. And then we also heard about here over the last couple of days that this is what is coming. We know that mutations that can be targeted and for which we have targeted drugs, they generally do better. We definitely saw it with Adura. We definitely saw it with Alina. But all of these different mutations or alterations have had success in the metastatic space. And this is part of the effort from the LEADER trial to really screen and profile the patients and eventually enroll them on the neoadjuvant trials. Again, we discussed those neoadjuvant trials, whether NPR is a good surrogate or not. Many of these drugs are actually not cytotoxic. These are cytostatic drugs. How we are going to use this. And again, this is a very high-level scientific discussion. This is how we treat lung cancer, but how do we bring it out to the community? How do we bring it out to the community at this level? And likewise, then how do we stratify these patients and offer them these options? And we know this is all part of the trial, but it will take some time, but I presume that this will make it out to the community and standard of practice within the next few years. We'll have to continue to educate ourselves and patients on these topics. So as an example for over here, I wanted to kind of keep it neutral, but you can probably recognize that this is Denver, Colorado. Colorado has an extremely sophisticated healthcare system. There's about 3 million people living there. Those first mountains that you see over there, those are actually Flatirons, right, at Boulder at the University of Colorado. But it's interesting that the healthcare in Denver is designed in such a way you have the hospital, you have the university hospital, and then you have 5 separate healthcare systems who essentially own the hospitals. And all the other practices are, again, separate. So I work with a pulmonary group that employs 40 pulmonologists and critical care doctors and 80 hospitalists. And they actually cover sort of different hospitals across different systems. You have one oncology, Rocky Mountain Cancer Center, that's part of US Oncology, and they have essentially monopoly in this. So you can maybe understand the challenges of having different healthcare records and referral of patients and how sort of complicated it may be to try to work in multidisciplinary way in a seamless fashion in the community. And so this brings me to the point of the sequencing, because I feel like oncology now is sequencing. Without sequencing, there's no oncology. That's all we talk about here. Do you have EGFR? Do you have ALK? What is your PD-L1? And many more. And then what are the commutations? So this is the reality of the world as well. If you work in a major academic institution, you may have your own molecular pathology. If you don't have it, how are you going to choose where you're going to send this? And that brings another conflict of interest for medical oncologists and for different teams in terms of how are they going to perform profiling. And this is an $8 billion industry now, and it is estimated that it's going to be a $47 billion industry in 2032, because essentially all the decisions that we are making in oncology now are molecularly based. And so here is basically the prediction of what may happen. This is around the world, not just in the US. But based on the talk that we heard yesterday, I'm going to pitch it over here that these two guys will become billionaires by 2070, and they will steal money from all the profiling companies, and this will essentially be, these are going to be the new Google guys, Sergey Brin and Larry Page, and they will basically create the new industry of spaceomics. In the US, we're just going to have a space force, but over here in Canada,
this was your joke slide, right?
Sorry?
This was the joke slide.
This was the joke slide, but it worked. A couple people laughed, so that was very good. But excellent talk yesterday, and I actually think there is something to this. And then you can see over here when I mentioned about profiling, so we have numerous companies, right, who do this. There's a huge market, plus you have, foundation medicine, you have Guardant, etc. So this brings me back to the environment that I work with. I work with two medical oncologists who are part of the same sort of a team, but they have a different region. So even when we have multidisciplinary conference, they actually both do not log into that conference. So I have one conference in one hospital. So how is that really multidisciplinary if you have just one surgeon and one medical oncologist and one radiation oncologist? What is the confirmation bias in terms of how we do things? And then one of them prefers to profile through Guardant, the other one prefers to profile through Foundation Medicine. The pathologists are really confused about this, and we're trying to essentially solve this problem. There's another issue that I don't know if you are all aware, obviously not in a Canadian system where you have your sort of a one healthcare system, but there's a 14-day rule for Medicare patients, which means that if you actually do a hospital procedure, so let's say we have some patients who come in de novo with lung cancer, and so they need bronchoscopy and diagnosis, and we can get PET scan in a hospital, and we tell them, well, you have lung cancer. We obtain tissue, but if you send that tissue for profiling within 14 days of that procedure, it's part of the global fee, which means that the hospital will eat the cost, and the hospital does not want to eat the cost. So the only thing that you can do is actually wait for 14 days before somebody puts that order. That means that somebody needs to track the discharge, or somebody needs to track the 14 days before this can actually be ordered, and that essentially delays care. And especially, you can imagine if you have someone who's non-operative, comes with advanced cancer, and let's say they may have a mutation and could start on a treatment, and you can't really start them on treatment because you have to wait for these, you essentially have to wait, for the 14 days. And then there are obviously issues with yield and some of these other things, and so it does make treating patients really quite complicated with this 14-day rule. So, let alone, for all of us kind of who we discuss these different sort of biomarkers, different ways of, looking at patients. We heard about microbiome, we heard about, different techniques and different technologies, and some of these may really start becoming standard of care. And I'm sure that they will be adopted by academic centers very quickly, but I think we have a lot of work to do to be able to disseminate this. We have heard about, patients from Halifax, but these are also patients, in some other metropolitan areas where they potentially don't necessarily have access to such a level of expertise and nuanced decision-making as we discuss over here. And so this was actually a case from this week. I saw this patient in clinic on a Tuesday. This is a 78-year-old guy who in 2019, I believe, had a 2-centimeter renal cell cancer that was treated with radiofrequency ablation or percutaneous technique. And a medical oncologist sent me this patient basically saying, well, I think this is a MET, but then we did some sort of a phenotyping, and it looks like a lung, and it's 5 centimeters. And I said, well, if it's a lung and it's 5 centimeters, then boom, 816, give him, chemo nivolumab. He's like, well, I don't know. I think you should resect this up front. And I'm like, I'm a surgeon. I'm like, yes, I would have a margin. I can do a robotic lobectomy. There's still a margin on the PA. There's still a margin on the lower lobe bronchus, but I don't want to operate up front on a 5-centimeter tumor. And then he's like, well, but we don't really know if it's, because the kidney was clear cell, and this came back as a poorly differentiated carcinoma, and even he's telling me that it looks like it's probably lung. And so then he told me something like, well, I'm just going to put him on nivolumab alone. I'm like, well, there's really no standard phase 3 trial to put him on nivolumab, even though I understand that you could use nivolumab for lung and maybe for the kidney. So these are sometimes challenging conversations. I think that people are taking their time to adopt the therapy, to adopt the way we discuss things. Obviously, at this sort of a higher level meetings, I think there's still a little bit of hesitancy and fear to do this. We clearly need to find better ways and more accurate ways to type and profile these patients. I mean, this patient ultimately could be treated on a few different pathways. He could get resected. We could confirm that it's a lung and give him chemo and either treat him based on Empower 010, or if he has a mutation, treat him in the adjuvant setting. But still, these are sort of the challenges that still occur in the community. And so we have a lot of work to do. I don't know if you know what kintsugi is, but through some of my life over the last year, I have basically stumbled across this. And the art of kintsugi is actually bringing something that's broken back together and making it more beautiful than what it was before. We live in a fragmented world, especially in the United States. We work with organizations that are for-profit, that are siphoning money to investors from healthcare system. It's not the most optimal way to really, I think, treat patients in the current state of healthcare, where there is such a tremendous advancement, and even we sometimes have a difficult time keeping up with all the different choices. And I think this will only continue in the future. But I do think that if we keep chipping away at that, and maybe get a little bit of gold paste and try to bring together this fragmented world, maybe eventually we will have something more beautiful than what it originally was. So thank you very much.
Hey, get it back up here. Might be some questions. That was a really outstanding and I think important talk. Any questions for Dr. Sepeshi? John?
Did you do the one on the right? No. Honestly, that was a great talk. So you highlighted a lot of challenges in your healthcare system. Is there anyone working towards solutions? I mean, it sounds like these are integral, systemic issues that are not really easy to overcome.
Well, actually, thank you. I'm really glad you asked me this question. I know that we have people here from industry, and I would have to sort of give them a shout out, because all of these trials that have happened, they happen on an international scale, because they sort of took over some of the slowness of the process through cooperative groups, etc. And I think that, again, I think our collaboration with industry, I think will be important in this regard, in terms of creating educating sort of education documents or short videos, or sort of working together with larger organizations to find better streamlined processes of how to deliver this highest level of care that already we have based on phase 3. So I do think that it will require an effort at a higher level, and I think it will require collaboration of the industry with healthcare systems.
Thank you.
Boris, I'm curious, what was the concern of that medical oncologist to start chemo-nivo?
He felt that even though he told me himself that the typing looks like lung, he's still sort of thinking, what if this is a solitary kidney? And he felt that the systemic therapy for the kidney and the lung are different. The only commonality that he could have found, but I told him that there is enough evidence that this is lung, and I would start chemo-nivo for the lung. For the 3 cycles, it would make my operation perhaps even easier, or as we discussed, depending on the response, he could be consolidated with radiation or what have you. But I could not find a way to convince him.
Yeah, we've all experienced this. Thanks.
Yeah.
All right, thank you very much. That was a great session.